Beautiful. And our next speaker is Dr. Carlos Singer. And Dr. Carlos Singer is professor of neurology at the Miller School of Medicine of the University of Miami. He served as chief of movement disorders from 2002 to 2020, and currently serves as the director of the Parkinson Foundation Center of Excellence and co-director of the Huntington Disease Society of America Center of Excellence. He received his medical degree from the Central University of Venezuela. This was followed by training in internal medicine at the University of Pittsburgh. I happen to be bilingual, it just happened. And in neurology at the Albert Einstein College of Medicine affiliated hospitals. And he received his additional training in electromyography and in movement disorders at the University of Miami. He is board certified in both internal medicine and neurology, and he's been a member of the faculty department, the Department of Neurology of the Miller School of Medicine, University of Miami since 1989. Thank you, Dr. Singer. You are next.
Well, hello, everybody. Ooh, have to come down from the little musical trip. Hey. Okay, so, and this is a combined talk with my colleague, Dr. Jason Margoleski. So we have to run through this kind of fast, but succinctly, and then we'll cover it at the very end with a panel discussion. So we're going to cover, Dr. Margoleski and myself, the non-motor problems in Parkinson's disease. My part deals with below the brain, blood pressure, gut, bladder, sleep. All of those are centers located in the brainstem, below the brain. And then Dr. Margoleski will cover the brain, all of the problems that are non-motor involving the brain itself. So we will cover blood pressure, gut, bladder, and sleep first, and that will be my part. So the first one has to do with blood pressure. So orthostatic hypotension in Parkinson is a drop in blood pressure upon standing up. It is seen in 30 to 50% of patients with Parkinson's disease. Only about a third have symptoms of it. And the prevalence increases with age and with the disease duration. So we consider it significant. It's somebody's high pressure, the systolic, drops 20 or more points, or if the diastolic drops 10 or more points when they stand up. That will give rise to symptoms. If it's less than that, it may not give rise to symptoms. And it's not everybody who, so if we find that in a patient, we know that that patient off and on is having symptoms related to that. And what they experience is dizziness, faintness, or actually faint, visual fade outs, fatigue, and a type of pain in the back of the neck and the shoulders called coat hanger. But it happens only the moment they stand up or if they've been standing up for too long. One can view this problem of blood pressure drop as the result of contribution from outside the nervous system, not caused by the Parkinson. For example, not enough fluids or the side effects from medications, including the anti-Parkinson medications, and inside the nervous system caused by the Parkinson's disease itself. The contributing factors are meals, because with meals, your blood pressure has a natural tendency to go down. Exercise and diabetes. Drugs that can cause low blood pressure include the anti-hypertension medication, the bladder sphincter relaxers such as tamsulosin, so that or Hytrin, for example, or what's the name of the other one? The tamsulosin, Henry. What's the tamsulosin? Flomax. And then dopaminergic drugs. Dopaminergic drugs are the ones that we give our patients to control the blood pressure, to control the Parkinson, and the blood pressure drops. So we need to be aware of all of these possibilities when we detect this low blood pressure in patients. So we do a number of conservative things. We will look into the possibility of taking away some of the medications, including the blood pressure medications, or talking to the internist about it, or talking to the urologist about the sphincter relaxer medications. We avoid large meals, especially high in carbohydrate meals, or multiple meals are recommended in some cases. Increase water intake up to 2 liters a day, or increase salt. And we have 4 major medications that we use. They're listed here with some of their side effects. They include fluorocortisone, they include midodrine, which is also known as proamethine, droxidopa, and pyridostigmine. The latter we use more as a added on to the other 3. We go now to the gut. When it comes to the gut, we have multiple symptoms. We're going to concentrate on constipation, but you can have weight loss. You can have weight loss based on problems with the gut. Specifically, you can have weight loss related to trouble swallowing, which we call dysphagia. You don't feel like eating because eating becomes a little bit of a problem if you have trouble swallowing. Drooling or excess saliva, gastroparesis, which means the stomach empties slowly, constipation, which we all know what it is, and weakness of the muscles that allow for the bowel movement to happen. So the constipation in Parkinson includes, by definition, it's fewer than 3 bowel movements a week. More than 50% of Parkinson patients have it, and it may appear even a few years before the patient has Parkinson's disease symptoms. Conservative management is called fluid, fiber, and fitness. 3 Fs. Increase fluid intake, maximize dietary fiber, increase daily activities. This is what the definition. In the middle, you have the rounded teaspoon. This is the rounded teaspoon. And if you give Metamucil, you want to give more or less a rounded teaspoon of that powder, 5 grams twice a day. You can use Miralax, there is the dose. You can use lactulose, 1 or 2 tablespoons once or twice a day. And then there are medications that are used in irritable bowel syndrome that we may find useful, but you got to be careful because sometimes they can be too potent. So that includes lubiprostone and linaclotide, or Amitiza and Linzess. Neurological problems in Parkinson that involve, in other words, primarily the bladder. With Parkinson, you can have urgency and urge incontinence and frequency, and going frequently to the bathroom during the night. Talking about urgency, it's a disorder of bladder storage. There's more than 50% of Parkinson patients have it. It increases, the prevalence increases with disease severity. Mechanism is the bladder starts firing when it shouldn't. So it's an unruly bladder, if you will. Correlates with excessive bladder contraction. So the person's bladder contracts when it shouldn't, and that gives rise to the sense of urgency. What is important is that we have a number of medicines that we try to use for our patients for this problem. Many of them, the majority of them, can have the anticholinergic side effect, we call them. And there they're listed for you: dry mouth, dry eyes, blurred vision, urinary retention. So that's too much of a good thing, right? Instead of having to go to the bathroom, now you find yourself having difficulty going to the bathroom. And constipation itself causing constipation. So all of those are factors we keep in mind. And the side effect of the central nervous system is some of it penetrates the brain, aside from the bladder, and then it causes problems with memory. And we have to be very aware of that. So there is a hierarchy of preference. We prefer, of these anticholinergic drugs, we prefer solifenacine or Vesicare. It is much more selective for the bladder, although it can still penetrate the brain. We also, these are almost as good. You have them listed here: trospium or Centura, tolterodine or Detrol, and darifenacin or Enablix. Least favored ones are oxybutynin, orditropan, and fesoterodine or Tovias. Those are the ones that are more likely to cause the problems with cognition. Now, this is the real champion, the mirabegron. The only side effect of mirabegron is that, well, it's not true. It has side effects, but the main side effect is insurance coverage. Okay, and this is a problem that's pervasive in our system, but that's for another talk. Posterior tibial nerve stimulation is something that urologists may use. It's interesting. You stimulate a nerve in the leg, and that seems to have some sort of calming effect on the bladder for a while. It's very non-invasive, very safe. Not so safe, but very effective is botulinum toxin. The same you use for wrinkles can go into the bladder, can be injected and can last up to 6 months. That's only for cases of severe urinary urgency because it can have its own set of complications. Finally, if somebody has a weak stream, one has got to watch, it may be too much of these anticholinergic drugs, or there could be a stricture or a prostate hypertrophy. So it's not as much a symptom of Parkinson, it's a symptom outside of Parkinson. Now with sleep, you can have fragmented sleep, you can have what's called REM behavior disorder and sleep apnea. Fragmented sleep, multiple wake-ups during the night, maybe in part due to rigidity, need to empty the bladder, vivid dreams, poor sleep hygiene, meaning you go too much light instead of dimming the lights as you're getting ready to go to bed, too much cell phone, too much iPad, too much TV, etc. Fragmented sleep for medications, this is my personal preference. Mirtazapine, I believe, is quite good, and I mentioned the doses there. Trazodone is also fairly effective. Doxepine is one of the most studied ones in Parkinson. And then you have the Z drugs. This is Ambien, Lunesta, and so on. Sometimes you have to use those, or even clonazepam, which is a long-acting benzo. Vivid dreams. Now, REM behavior disorder is the vivid dreams fighting in the sleep. It can cause potential harm to the patient. Patient could fall out of bed or hit their head against the night table, and spouse. Melatonin is the main treatment, or at least the initial one, and you can give up to 20 milligrams at bedtime, totally safe. If it's not responding to that, you can use clonazepam, 0.25 to 2 milligrams at bedtime. And sometimes we use the anti-hallucination drug, quetiapine, as it provides for a deep enough sleep and changes a bit this behavior. Sleep apnea. If somebody snores and is excessively sleepy during the day, it could be a symptom of sleep apnea. They may need a sleep study. And attention to insomnia in general and sleep apnea in particular are important measures, not only to improve sleep, but to improve memory function. Thank you for your attention. Now